So we're going to hand you over now to Anne Buchanan on what we constantly make reference to when we do our local visit reports, and what we hope and have been battling with now for some time, as do we know in most nursing situations, is the care planning process. So over to you, Anne. Thank you.
Good afternoon. My name is Anne Buchanan and I'm a nursing officer with the Mental Welfare Commission for Scotland. And I was part of the original team involved in the draft of our Good Practice Guide Person-Centred Care Planning, and that was from 2019. Today we will revisit our guidance and also have an opportunity for Q&As following this presentation. It's helpful at this point to remind ourselves about Rights in Mind, our publication from 2017. We should start with everyone using mental health, dementia and learning disability services has the right to a care plan, which is personal to them. They also have the right to be involved in developing their care plan, to know what is in their care plan, and to be involved in reviewing their care plan. The purpose of the care plan. A care plan describes the care, treatment, and interventions that an individual should receive. To ensure that they get the right care at the right time, it's a written record of their needs, actions, and responsibilities, which can be understood by individuals receiving care and also their relatives, carers, and others where appropriate. The care plan is based upon a template, which typically defines the areas the care plan covers. Some care plans may be very simple and focus on the essentials, for example, mobility and nutrition, while others can be very detailed. We recognise that care plans are a crucial part of supporting and helping the process of recovery. The process of care planning should enable people to take more control of their lives whilst they are receiving care and treatment, and ensure their needs and aspirations are taken into account. We recognise that recovery in any form is in the eyes of the beholder. My recovery may look very different from yours, and the expectations of what you can or should do to enable my recovery may also look very different from your own expectations. What we know about care plans, it provides a written, possibly paper or electronic record of what a person needs, what actions will be taken, and who is responsible for those. We consider it a crucial document in terms of supporting the individual and enabling the recovery process. Involvement of the person, and where possible, their significant other, is also a key principle of the Mental Health Care and Treatment Scotland Act from 2003. What we know is that care plans are bespoke and they're person-specific. A care plan is a collaborative activity between the individual, their care team, and this should include a range of professionals from the multidisciplinary team. And let's have a look at care plan essentials. With this in mind, we therefore start with ensuring that we have planning in place. And this should include the views of the individual, significant people in their lives, and where possible, as previously stated, a range of professionals. We would consider care plan essentials. Furthermore, we consider the principle of participation. It is essential to involve people in their own plans of care. Active participation in care planning has become more prevalent in recent years, but it requires a concerted effort from all staff. Therefore, we are not referring to nursing care plans in this presentation. Of note, we do recognise for some people, establishing any sense of relationship with staff may be difficult for a whole host of reasons. However, it may be helpful at this time to invite family and friends to provide helpful information. For example, what helps, what hinders recovery. Not everyone will agree to this type of collaborative approach. Consider a good practice guidance published last year, Carers and Confidentiality, for any guidance and advice. You will find it on our website. So what we would consider as essential is the initial admission care plan should cover the first 72 hours of the admission, and after this time should be discontinued with a more detailed care plan put in place. Of course, liaison type services, a triage plan would be considered that covers the same elements as detailed below, but possibly in less detail. So what we consider are the key personal details, an assessment, the aim of any planned intervention, who is responsible for each intervention, when and where, evidence of the participation, consideration of capacity and consent, and safeguarding issues. And this would be in particular concerning risk, and of course, crisis arrangements. Principles to consider when care planning. So we're going to think about the nursing process. The nursing process is a clear and straightforward model consisting of 4 concepts of nursing: assessment, planning, implementation, and evaluation. The nursing process looks first at the individual and then thinks about the care that is required. The emphasis is on the individual assessment, encouraging nurses to identify the individual's potential. The assessment should lean towards assessing an individual's strengths rather than a deficit model of assessment. As with all care plans and processes, they require initial assessments and likely follow-up assessments. Agreement of which identified need would be considered as immediate, and of course which needs have been identified as important for the individual. Who will provide the intervention, an agreement of participation where possible, and importantly, in all processes, how interventions are going to be measured and reviewed. Without regular reviews, how do we measure progress? For additional views on the nursing process, please do refer to our guidance. At this point, it's important to think about and consider the views of individuals and carers. The following points represent the information that we have gathered from individuals with lived experience, their family. Think about what should be held in the care plan. Who were the significant people in their life, are currently in their life, and who would help with gathering information? Getting to know me is an appropriate tool for everyone. Plus, it's an opportunity to start conversation. People need to know they are safe, particularly in the environment they have found themselves in, and how the care team will achieve this, a sense of safety. People felt that many of the things that they would like to put in an advance statement might also appear in a care plan. So, for example, the purpose of the admission, what it is to achieve, who will support me, and how will I know that my voice is being heard? From this, we want to think about the scrutiny of care plans. A bit of background information around the Commission is probably helpful here. The Commission carries out approximately 150 visits with 2 national theme visits every year. On our visits, we find that the quality and level of participation from the individual with care plans varies considerably. We have broadened our visiting programme to include community mental health services. This is new for us. We have visited older adults, GAP, so that's adult services, and learning disability services. We reviewed the care and treatment of approximately over 1,000 individuals and 231 of their family members. Recurring themes from our visit recommendations is that over 30% relate to care plans. That includes the audit process, multidisciplinary team activity, and those included in care planning. This includes general adult psychiatry wards, older adults, learning disabilities, and dementia wards, who typically around 46% in relation to the recommendations for the care planning. We do know that local health and social care partnerships and health boards will have their own quality assurance systems and standards for auditing care plans. So let's have a think about auditing care plans. What we've been told by individuals, I have a copy of my care plan. It's useful to see how I have progressed. I keep a copy in my room. But for others, I'm not sure what a care plan is. In fact, I'm not entirely sure how decisions are made. During our visits, we are often asked to provide audit tools by staff. However, an audit tool we would suggest needs to be specific to that area. So what we would suggest is develop an audit tool that is based on the most important area that requires improvement. This ensures a consistent approach to care planning. Or you could consider one particular area or aspect of care planning. An example could be participation of the individual, their family, or maybe members of the multidisciplinary team. You could consider evidence of how information was gathered, how it was included, and how it influenced specific action or intervention. We make recommendations about care plans as we typically cannot find evidence of participation. Therefore, the care plan we would suggest is not person-centered. Where we see care plans that include views of the individual, family members, or the multidisciplinary team, we have a greater understanding and appreciation of the individual's needs, their strengths, and the goals that are important to them. During our visits, we ask people about their care plans. Were they actively involved in the creation, and did they feel it was meaningful to them? For some people, in the early stages of their admission, when they are unable to fully participate in care planning, it was helpful to have a starting point. For example, what were the triggers for their illness? Knowing that their home is safe and any issues that could be dealt with in terms of their home, perhaps security, their children, work, how that could be managed to reduce stress and distress. Lastly, reviews, evaluations, they are essential. Remember, where progress has been achieved, celebrate it, update, amend, or discontinue the care plan as necessary. Recovery does not look like the quote I'm going to give you, which is no change. Week after week or month after month. Progress may be achieved in a particular area. However, in other areas, it may take longer, and this should be acknowledged and a clear evidence of why progress has not been achieved. We understand recovery is not a linear route. That needs to be acknowledged. If no change is made, it's time to consider making one. For more information and detailed explanations, please do visit our Person-Centered Care Plan Good Practice Guide, and we have a reference here for you. And lastly, here's information about our advice line, contact telephone number, and our email address. Please do call our advice line. It's always good to hear from nurses. Thank you very much.
Thank you, Tan. That concludes our tour through. I think it's probably fair to say, as Anne's already highlighted, some of the bits that we pick up when we do our numerous visits is that there's an ongoing challenge that we appreciate for anyone, nurses, medical staff, social workers, anybody in completing a care plan or a thorough record of what's happening. But the other side of that is what we hear from individuals and their families and carers in terms of how useful that care planning process can be to the overall inclusion and progress that they can make. So we always feel that wherever there's an opportunity to highlight effective and good care planning and the training of it for staff and the supervision and the ongoing support of it, it's never a wasted opportunity. So thank you.